Hey guys, Connor Nickels here. We're going to be talking about bedside aorta ultrasound. So the objectives of this talk are we're going to talk about the anatomy of the aorta. We'll go through some of the indications for doing the exam. We will go through the actual technique for the exam, and then we will talk about some pathology and look at some images. So for this exam, we're primarily visualizing the abdominal aorta as opposed to the thoracic aorta. So this is just a schematic of the abdominal aorta, and as you remember from anatomy, the aorta runs parallel to the inferior vena cava. They both run along the spine. The abdominal aorta is to the left, and the inferior vena cava is to the right of the patient. We will talk about the different landmarks to measure, including the proximal, mid, and distal aorta, the proximal being the celiac trunk, and we'll talk about the branches of the hepatic artery and the splenic artery. The left gastric, as you remember, coming off the celiac trunk is actually never visualized in the abdominal aortic ultrasound exam. So we'll only see the celiac trunk, hepatic artery, and splenic artery. Then the mid aorta will be the superior mesenteric artery. Then the distal aorta will be the bifurcation. So there's our proximal, mid, distal, where we will be taking measurements during the exam. So what are the indications for an abdominal aortic bedside exam? Our primary reason for doing this is for an abdominal aortic aneurysm, and the definition of an abdominal aortic aneurysm would be anything greater than 3 centimeters. So a typical aorta is going to measure anywhere from 1.5 to 2, but we consider anything greater than 3 centimeters to be an aneurysm. About 2 to 5% of the population is going to have a AAA, and the prevalence is higher in first-degree relatives. It's also about 4 times higher in men than in women, and there are other risk factors like smoking, hypertension, high cholesterol, atherosclerotic disease, and a AAA rupture is directly related to the largest diameter of the aneurysm, and it increases each year or as the aneurysm gets larger. Women usually are at higher risk of rupture than men are, even with the same size aneurysm. And unfortunately, most people are completely asymptomatic until the aneurysm ruptures. So it's not like they come in with this diagnosis telling you, oh, by the way, doctor, I have, an enlarged aorta and I'm concerned about it. They just come in with their symptoms and you have to figure out what's going on from there. So different types of aneurysms. We have our normal, intima, media, adventitia, which are the layers of the aorta, and then we have our true aneurysm, which involves all 3 layers, and then a false aneurysm would only involve the outer layers. And then a dissection obviously is not what we're talking about, but that's when you create 2 lumens, and this can be picked up on ultrasound, but it's not the definitive test for that. And then there's also fusiform aneurysms and saccular aneurysms. Fusiform would be the entire 3 layers, dilating the entire diameter circumferentially of the aorta, whereas a saccular aneurysm would be like an outpouching, like a grape on the side of the aorta. So if you remember from medical school, the classic triad of abdominal aortic aneurysm: abdominal pain or flank pain, palpable abdominal mass, and hypotension. So anybody have any idea about how often this occurs? How often do patients present with all 3 of these symptoms who actually have an abdominal aortic aneurysm? It's going to be very minimal. Less than 25% of the time people are going to present with all 3 of these symptoms. About 50% of the time people will have hypotension, even less palpable mass. I think it's less than 20% would have a palpable mass. And even I've had people come in saying they have a palpable mass. I mean, I can feel my own aorta lying in bed, and it's definitely palpable. So depends on the body habitus of the patient as well. And it doesn't necessarily mean that they have an aneurysm. So pain is the most common thing that you're going to see, and it's not really specified. You know, it could be groin pain, flank pain, back pain, abdominal pain, but 80% of the people that present with an abdominal aortic aneurysm will have pain. So what are some of the other indications for doing this exam, other than those three things in the classic triad? So here's just a few. Unexplained hypotension, and this could be actually somebody with normal pressure, but a lower pressure compared to their normal pressure. So say somebody's hypertensive all the time and they're, 180s over 110s, and they come in with a blood pressure of, in the 1 teens, then that's a lot lower than their normal, but it's not technically hypotension. So that could be an indication. Dizziness, syncope, cardiac arrest, groin pain, testicular pain. You just really have to have a high index of suspicion, especially in patients older than 50, to think about these things. I have had one case of a patient die who had a AAA, and I was a fellow. I was doing my fellowship at Orlando Regional, and I was working as an attending at Florida Hospital East. And at the time, they did not have any ultrasounds there, so I was unable to do a bedside exam. Sweet little Hispanic male, probably in his 70s, comes in with his family, said he was having I can't remember if it was left lower quadrant or right lower quadrant, but he was having lower abdominal pain on one side or the other. I remember he had a low-grade temp, less than 101, maybe 100.4 or 100.2. And I gave him 4 morphine, and he was perfect. He was watching TV with his family, talking. Every time I went to check on him, he had no pain. I had asked him about abdominal aortic aneurysm and his history. He, of course, didn't know of any history of that. That was not number 1 on my differential, but definitely was on my differential. So I was more thinking, depending on which side it was, and like I said, I can't remember, it was either appendicitis or diverticulitis. So we had ordered a CT, and he definitely did not have, guarding or anything like that. He was just minimally tender. So, being a busy ER, it took hours for some reason this day. Finally, about the 3rd hour, I called CT and said, when are you guys going to get this guy down? I really want to get his CAT scan. So finally, they take him down about 3 hours after I'd ordered it. Suddenly, I hear code blue in CAT scan, code blue in CAT scan. And I knew exactly what had happened, and I was just devastated. The patient comes back, and he had ruptured into his peritoneal cavity, which, as you know, sometimes the aneurysms rupture into the retroperitoneum. It's actually more common to rupture into the retroperitoneum, which is actually more deceptive, because once you rupture into the retroperitoneum, then you can tamponade off the bleeding, and the patients can be normotensive and, have what appears to be stable vital signs. And so this can be very tricky to deal with. But he came back looking like he was 12 months pregnant. And, I had to tell his family that, there's no point in even running this code, because I know what happened. And, he died of an aneurysm rupture, and there's nothing I can do to bring him back. And thankfully, the family was very, understanding, and, they were just so kind and, so appreciative, and kept thanking me, but I just felt awful for him. But, it just reminded me that, wow, that was not textbook. That definitely was not the classic triad, I can tell you that. So, just have a really high suspicion for these type of things, because you never know where the aneurysm is on the abdominal aorta. The majority of aneurysms are infrarenal. However, anywhere along the aorta they can occur, and, based on the different fibers that run along there can be referred pain to different areas, and so it can get tricky, like I said, to figure out what's going on. So, this is just a graph of showing the size of the aneurysm and the rate of rupture per year. And I believe the vascular surgeons in men, which is the majority of cases, usually will try to repair it around 5.5 or 5, depending on the patient, their risk factors for surgery, and all of those type things. So, at any point, even if it was smaller, even if it was less than 4, greater than 3, but you were concerned, small aneurysms do rupture. It's just a lot less of a percentage of the time. So any questions, you can always call vascular. And obviously you would have them follow up with vascular. So what is the mortality rate for a ruptured AAA? So we already talked about how it's not good to rupture. And so I think you can imagine that the mortality rate is not going to be good. It's going to be pretty high. So mortality rate is about 75 to 80%. So those people that have ruptured AAAs and then undergo repair and live, about 75 to 80% of the time they're going to die. So what's the goal, obviously, for us in the emergency department? The goal is to decrease the time to diagnosis. So if you can diagnose that abdominal aortic aneurysm prior to them rupturing, then you have done them some justice, and hopefully they will survive if they have to have it repaired. So as far as emergency physicians performing bedside aortic exams, what do you think the sensitivity, specificity, or accuracy would be? So the overall accuracy is about 100%. So when you combine the sensitivities and the specificities, it's a very simple exam, and you can have very minimal training, and you're able to diagnose these. So this was a study, there's multiple studies out there, and this is an older study, but I love this study by Plummer in Academic Emergency Medicine, 1998. It was a retrospective study, but they looked at 50 patients that had ruptured AAAs. 25 of them had had a bedside ultrasound. 25 of them did not have a bedside ultrasound. And so those that had had an ultrasound, the time to diagnosis was 5.4 minutes. The average time to disposition, meaning figuring out what's going to happen, are they going to the operating room, calling vascular surgery, getting them involved, was only 12 minutes. Those that did not have an ultrasound, the time to diagnosis was 83 minutes, because as you can imagine, they probably had multiple other tests, probably CT. And with our wait times now, those CTs can take quite a long time. And then the average time to disposition was 90 minutes. So the most important thing is that those with an ultrasound early on had a 40% mortality, compared to those that did not have a bedside ultrasound had a 72% mortality. That's a pretty broad range. So obviously the patients that had, quicker time to diagnosis getting a bedside ultrasound had a much higher chance of survival. So let's talk about the technique. So you can use the phased array probe on the left or the abdominal curvilinear probe on the right. Most of our machines only have the phased array on the left. The trauma machines only have the phased array. Our new exports only have the phased array. Some of our older turbos have the abdominal curvilinear. Again, I usually prefer the abdominal curvilinear if it's possible. But both of them can image the abdomen quite well. So in positioning the patient, you want to have them supine, and you want to make sure that you expose the area from the xiphoid down to the umbilicus, because that's the area that you're going to be scanning. And again, the aorta bifurcates at usually around the umbilicus. So you want to scan through the aorta in transverse and sagittal planes. So which plane do we want to start in? Any ideas? So we're going to start in transverse, and the reason that we start in transverse is because this gives you the most accurate measurement of the aorta. And the reason for this is if you take this tube and you pretend that we're scanning the patient in sagittal as opposed to transverse, if we start in sagittal, then your ultrasound beam may come down and cut the aorta about here, or it may come down and cut the aorta about here. If you take these diameters and measuring them, they're obviously quite different. So this is called cylinder tangent error, and you don't want to make this mistake. So in order to get the most accurate, quickest measurement of the aorta, especially when you're worried that the patient has an abdominal aortic aneurysm, we start with transverse because it gives you a face-on view of all the diameters of the aorta, or entire circumference of the aorta, I should say. So starting in transverse, we're going to be all the way up into the xiphoid area, as high as we can go, while keeping the transducer perpendicular to the patient. Your indicator's to the patient's right. And so what is the landmark for finding the aorta? I talked about it at the beginning when we talked about where the IVC and the aorta ran. So the spine is our landmark. So you want to find the spine first, and that will allow you to better find the aorta and the IVC. So again, we have our patient supine, we're up in the subxiphoid area, and then this would be the image that you're getting on the right. So just to zoom in on that, we'll look at spine, which gives you a clean shadow because it's a bone. The IVC is on the left side, and then the aorta is right above that. And you can see all of the edges of the aorta, and that would give you the most accurate measurement. So you want to visualize and measure the aorta at each segment. So like we talked about, the proximal, mid, and distal. So when you do a measurement in transverse, you're going to measure perpendicular, two measurements perpendicular to each other, and you want to make sure that you measure on the outside of the calcification. So you look for the bright white, and you measure on the outside of that. And as you can see down here, A and B, it's not greater than 3 centimeters in this particular case. So our first, or proximal aorta, is the celiac trunk. So again, we are in transverse. The only difference in this one is a lot of times when you have the transducer exactly like it's being held in this picture, you're looking at the SMA. So in order to look at the celiac axis, sometimes you have to tilt the probe up slightly like this. So this would be a great view of the celiac axis with our hepatic artery and splenic artery. This is beautiful. This is not what you're going to see every time, but I at least want you to have the picture in your mind. You can see over to the right side of the image, that twinkling, that's a great example of bowel gas and dirty shadows, unlike what you see behind the spine. So spine, aorta, celiac trunk, hepatic. On the left, the green is hepatic, and then the right is splenic. And the hepatic and splenic just make something called the seagull sign that looks like a bird. This is just an example of a more real life, not pretty celiac trunk. And as you can see right by the liver to the left right there, it's kind of leaning over to the side. So here would be the example of that. So celiac, and you can see the spine below with the bright white, and then the aorta is not, all the walls are not visible in the aorta, but you can see where it starts there, right above the spine. So our mid aorta would be superior mesenteric artery. So again, pretty much we just stand it straight up rather than looking up, and it's just remarkable how close the celiac axis and the SMA are. So it almost looks like they share the same trunk in some instances, although they don't, but they're very, very close in approximation. You can sometimes get them in the same cut. So looking there, spine, aorta, and then SMA is a dot. So you're seeing it like an end-on dot or transverse cut of the SMA, and then you can see the splenic vein that goes right above it. So celiac, and then you can see there's that same video with the, I'm sorry, celiac, that's SMA, and then you can see celiac right there. So it's the same video from the celiac trunk. So I just want to show you a lot of images so you're able to kind of get in your mind where everything is. And the good thing about us doing these voiceovers is that these lectures will be available to you at all times. So that'll be nice because then you can go back and review them. And, you know, it's not like you've only seen it one time and then don't have access to it. So you can see that the left renal vein comes between the aorta and SMA, and that's, if you remember from like pediatrics, you can get the nutcracker syndrome, and that would be where it's real dilated on that right side. I guess the left side of the patient, right side of the image. But you can see it's definitely a vein. It's attached to the IVC, and then you can see the splenic vein, and I just drew that little tiny line because it looks like it's compressed on that side, but I wanted you to realize that those green things are all one vessel. So dirty shadow from Bowel, again, another image. Pancreas lies right above the splenic vein, so you'll see the renal veins, or at least the left renal vein, and then the right and left renal arteries. If you scan up and down, you just have to pay attention to exactly what part it's coming off of, whether it's the aorta or IVC. Again, here's another example of the SMA. So, like we had with the celiac, we had the seagull sign. This is more like the clock face, like an antique clock that they describe for the SMA and splenic vein. And then the bifurcation is the distal aorta. So we're gonna slide our probe down to about the umbilicus, and you really need to fill that belly button up with gel, because if you don't have any gel in there, then the image will look blurry because there'll be air within the belly button, and then you won't be able to see your image. So really make sure you have enough gel in there and press pretty firmly to make sure that there's no air within there and you can clearly see the bifurcation. So here is an example. As you can see, if I go back to these, where we're at, if you see the 13 at the bottom of the screen, we're at 13 centimeters here. And then if you look at our bifurcation, we're only at 9 centimeters. Anybody know why we're suddenly becoming more shallow? We're at the bifurcation. So we talked about how the aorta runs along the spine, and what does the spine do lower down? So you have the normal lordosis of the spine, where the spine comes in right about the pelvic area. And so the aorta is actually coming closer to the probe, down near the bifurcation. So you can see here when it bifurcates, those are the iliac arteries, and you can barely follow them. It's just a very short distance where you can follow them, but you want to kind of get an idea of, you know, that they look symmetric. And so the normal diameter of the iliac arteries is 1 centimeter. Each one would be 1 centimeter. Aneurysms would be like greater than 1.5 centimeters. Another a little bit less clear example of the aorta, but you can see where it bifurcates right about there. You can see sometimes shadowing becomes an issue. Bifurcating there. Okay, so now that we have scanned the aorta and transverse, we're going to go back and scan the aorta and sagittal. So we go back to the subxiphoid area, indicators towards the head, rock up into the subxiphoid area, and you're going to get a great view of the aorta. So you can kind of get it going along the entire screen, and you see what looks like the rabbit ears there. Those are your celiac trunk and your SMA, and you can see how close they are. So liver up top, celiac trunk. So head would be on the left side of the screen. Right side would be feet. So celiac would be the most proximal, then SMA, spine down below with the shadowing. So you must be able to differentiate between the aorta and the IVC. This is really, really important. There's multiple ways that people look at this. Some people start in transverse with the aorta in view and then turn on it. I really don't like that myself. I think Dr. Flock does that, but I just seem to lose my orientation. So for me, I usually rock up in the epigastric area. I find what I believe is the aorta or IVC, either one. I try to find what I believe is the aorta, and then I just look to the patient's right to visualize the IVC, which is going to be more floppy and compressible, and you should see liver on both sides of it initially up, towards the heart. And then if you rotate or fan more towards the patient's left side, then you'll again look at the aorta. And so you can differentiate between the two. They're both going to pulsate. It's just the IVC is a floppier pulse than the aorta. You just don't want to lose it as you're scanning down because you don't want to be measuring the IVC instead of the aorta. So I know this is a grainy image, but let me try to orient you. So the heart is kind of at the right bottom of the screen beating. And then the anechoic area line kind of coming off to the left of that is the IVC, and you can see liver on both sides. And then right there is the aorta, back to IVC. You can see the first hepatic branch coming off. And I just barely show you aorta for a few seconds, but you can see how floppy the IVC is. There's aorta, IVC. So this is the IVC. So you can see liver on both sides. So this is the same image, but I'm just focusing on IVC, and you can see how floppy it is and compressible. And then this is an image. This is just 180 degrees flip, so don't get confused from that. So this time the heart is at the bottom because the previous image I had it in cardiac preset, and this one's an abdominal preset. Don't get confused by that. Just know heart is at the bottom left side of the screen now. And you can see the first hepatic branch of the IVC coming off. You can see the IVC going up. And then above that, where those little white outlined circles are, that's the that's the hyperechoic. Sorry, I'm blanking. It's the gallbladder, but the portal system. Sorry. So the portal system is bright white. All the bright white within the liver is going to be hyperechoic because it's lined with fat. And then you can see gallbladder where it looks like it's going into the portal vein. And IVC just below that. And then the anechoic structure at the very bottom is the aorta. And I'm kind of fanning between the IVC and aorta. And you can see the spine behind that. This is another example of the aorta in sagittal with the two branches. Another example of the aorta. Again, the branches there are a little bit less clear, but again, this is the aorta. You can see the branches coming in and out. So you want to slide down following it and keeping it in view, just kind of fanning right to left while always keeping it in view as you go down to the umbilicus. You can take measurements along the way, and you want to kind of keep them, in diagonal. Again, remember how we said that the aorta becomes more shallow, so you can see that's why it's diagonal, head being at the left side of the screen, feet being at the right side, and it's, coming closer to the top of the screen, which would be where the probe is touching. Just another example of the sagittal aorta and coming down to the bifurcation. And this is a beautiful example of a bifurcation. It definitely does not always look like this, but I just wanted to show you how you can see the bifurcation there. Normally you will just see the aorta coming and then it just kind of disappears. So what are pitfalls to performing this exam? So there's a few, and we've kind of talked about them, but bowel gas. Bowel gas is definitely an issue, especially in more obese patients when you have, kind of a longer distance to get to the aorta. So there's a couple of remedies. One is firm pressure, firm, steady pressure in the exact same position and just waiting. Or you can turn the patient in the left lateral or right lateral decubitus and try to find the aorta from there, and that might help the bowel gas get out of the way. But a lot of our patients are unable to turn. Obesity, again, firm pressure. Um, and there are different, like on the new export, there's two bodies to the bottom right of the screen. One is a fat looking body and one's a skinny looking body. And those are just the different body habituses, whatever the term is. But so if you're doing an exam on a fluffy patient, then you want to choose the fatter image, and that just changes the penetration on the screen. And you can do the same thing with the turbo, just changing the residual to like general penetrating. It's up on the bottom of the screen on the left. We'll be toggling through the buttons. But sometimes that will help you get a better view. And then IVC versus aorta, which is what we just talked about. And then obviously faulty measurements. So faulty measurements is a pretty serious thing, something you don't want to do. And we're going to look at a few of those in the next cases. But when you have an abdominal aortic aneurysm, when it gets really large, you tend to get a mural thrombus. And the mural thrombus is hypoechoic, and as opposed to the lumen. The lumen is anechoic, like where the blood is actually flowing, and then you have this mural thrombus, both obviously within the aorta. And so some people tend to measure the lumen, which is anechoic, giving you a smaller diameter of the aorta, when really it's the entire aorta, including the thrombus, which then is clearly an aneurysm. And so you don't want to make that mistake. And I'll show you some examples of that. So case one, here's an example, and I'm sure you can see what looks like lumen and thrombus. So you can see spine, and then aorta is this entire thing. And again, follow the white, because the white or hyperechoic area is the calcifications, because obviously aneurysms usually happen in older people with atherosclerotic disease, and so they're going to have calcifications around the aorta. So you can pick out these hyperechoic areas and measure on the outside of those. So this would be the thrombus and then the lumen. So you definitely do not want to measure just the lumen. You want to measure the entire aorta. So similar case, measure the entire aorta. This patient, 5.28 centimeters. And this is just putting color on there. You can see that the lumen obviously there's turbulent flow, which is what you get with, when you start getting an aneurysm. And it's just flowing through the lumen, and obviously the thrombus, there's no flow. So case 3, as you scan down, so initially it looked like the aorta was fine, and now the aorta is getting bigger. Now it's getting smaller. And you can see the calcifications. And then there's a thrombus right there at the top. So you want to measure that entire aorta, which is huge, 6.42 by 5.95. And then this would be measuring the same patient in longitudinal. So we're scanning through in long, and it gets difficult when they get older because the aorta can become very tortuous. So it's hard to stay right in the center. But in scanning through, you can see that mural thrombus and then the lumen there. And then another example of an enlarged aorta. Again, thrombus and lumen, very irregularly shaped. This is just a CT cut where you can see the entire aorta, and then you see the lumen, which can be very deceptive because you would want to measure that lumen, which is where that dye is. That's perfectly circular there, which looks normal. But if you look back behind it, that's thrombus, and then you want to measure all the calcification. So you don't want to miss that. That's a huge aneurysm. Again, same thing, thrombus circumferentially with lumen in the middle, but you want to measure the entire aorta. Same thing. How many times can we go over this? But it's the most important part of doing an abdominal aortic scan, because this is what you're looking for is an aneurysm, and then you don't want to not be able to measure it correctly. This again is longitudinal. You can see that fusiform aneurysm, and then it becomes small again, and it's normal diameter, kind of on either right and left of the screen, but it's large in the center. And this is kind of a crazy case. You can see the Siegel sign right there, celiac axis, and then you also see the SMA right below it. And then aorta down with the little floppy thing in the middle. So what's the floppy thing in the middle? So the aorta sitting on top of the spine. Another view of the same. You can see those calcifications at the top, that big thrombus. Scanning through. So this is an intimal flap. So this patient not only has what? We have two things. This is in longitudinal. Again, you see that floppy thing in the middle. Measuring in longitudinal in different areas. You can tell the measurements change. So this patient has a dissection and a AAA, which is pretty uncommon, but thought it was a pretty cool case. I wanted to include. So again, you can pick up dissections, but it's not really the indicated reason that we do the study. It's not the gold standard for picking up dissections, but you can pick them up. The gold standard would be CT. So hope you guys aren't asleep by now, but this is my Truman Oliver Nickels, aka Ton. If you have any questions on aorta, email me, cnickels@ufl.edu. Thanks.